Chairman, ladies and gentlemen, first of all, let me thank you, the organizers, for inviting me here. It's my first time in South America, and I must say I've really enjoyed thoroughly wonderful hospitality I've had since I came here. Also, I would like to bring you greetings from two societies in trauma from other parts of the world, the European Association for Trauma and Emergency Surgery and the IATSIC, the International Association for Trauma Surgery and Intensive Care, which are internationally based, and have the privilege of presenting them at this moment. So, okay. First of all, I come from Helsinki, from Meila Hospital, which is the part of the university hospital complexes in Helsinki. It's a big hospital with about 14,000 emergency admissions at the moment. Quite a few of them are acute abdomen, but most of them were not trauma. We have a lot of stab wounds, which might be a surprise to you, which is the reason why we have done a lot of studies on abdominal stab wounds. This is the list of the studies we've done. You can see now for about 10 years or so, and the discussion I'm going to have in the next 15 minutes will be based on those 5 studies from our hospital involving abdominal stab wounds. In the literature, you know, the approximate frequency of significant organ injury in abdominal stab wounds, which is about 40 to 50% in anterior stab wounds, but much less if you go to the flank or back, and a little bit higher on the thoracoabdominal stab wound population. And the problem, of course, is that sometimes you have an injury which doesn't need to be treated, a non-bleeding liver or splenic injury, for example, or a mesenteric injury that doesn't bleed, or sometimes you don't have an injury at all. Now, this is a list of significant organ injuries. I think we all agree that these should be operated on or treated operatively in most cases. And if you have an injury like this and do a laparotomy, it's therapeutic, or useful, or necessary if you like. If you don't have any of these injuries and you do a laparotomy, then it's unnecessary. If it's completely negative, you don't have any injuries. If it's only patients with minor injury, then you have a non-therapeutic laparotomy. So our first study, which we done some time ago, where we had the mandatory laparotomy policy, which means we operated on everybody who has a stab wound in the abdomen. And out of the 450 or so, 1/3 of them were non-therapeutic. And that unnecessary operation was associated with about 20% morbidity rate. So it's not innocent at all to do an unnecessary laparotomy. Now, what is the alternative? Of course, it's a selective approach. You operate on some, and the question is then how do you select the patients? And there's always a risk of delayed treatment of significant injuries if you do a selective approach. Our second study was a randomized study about 10 years ago where we excluded patients with immediate operation and also those with superficial injuries, and then randomized the rest to either laparotomy or observation. And the end result of that study basically was that there was no difference in the outcome of the group, which was really non-operative, although some of them actually required a delayed operation. Overall, the strategy was safe, and the conclusion was that it's a safe approach to treatment of these patients is non-operative, and also it's a good strategy if you want to decrease the amount of days in the hospital length of stay. So who needs to be operated? The patient with stab wounds in the abdomen. And we have seen the list of all the available diagnostic equipment modalities we have. I'm not going to go through all of them, just briefly to summarize what we know about all this. Physical examination, of course, has to be part of the picture, but by definition, it misses injuries which don't have symptoms or signs in the early stage. Of course, if you repeat the examination a few hours later, the reliability increases. Local wound exploration under local anesthesia is a good method. We use that, but it has some limitations in obese patients who are very athletic, and also in the thoracoabdominal area. So it doesn't solve all the problems. DPL we heard about is good, but it has high false positive rate. Ultrasound is good in unstable patients. We use a lot of fast ultrasound examination to detect free intraperitoneal fluid. It is unreliable in characterizing bowel injuries as well as pancreatic and diaphragmatic injuries. So ultrasound doesn't solve the problem. Now these are available immediately, more or less, if you think in the emergency department. And our third study was a retrospective study of about 200 consecutive patients with stab wounds. You can see the epidemiology and also the reason why in Finland we have so many stab wounds. They're usually alcohol related, usually happen during the weekend, and it's because the way Finns are drinking alcohol, which is a lot fast. In this study, with the overall mortality was very small, we tried to identify patients or indications for immediate or early laparotomy in this patient group. And we did an analysis and found out that the positive predictive value for patients with shock on the admissions or other signs of continuing hemorrhage or generalized tenderness or peritonitis, these, when there, are good indications to move on to do exploratory laparotomy based on those findings only. Also, if you have a patient who's vomiting blood or has blood in the stool or has bowel content coming out of the stab wounds, it's a good indication, 100% success in finding the patients with significant injury. But there were only 3 patients in this series with these kind of findings, so we don't have it very often. Also, if you can exclude the peritoneal penetration on local wound exploration, that is a pretty good sign of not needing to do a laparotomy. But if you look at all the others, mental evisceration, proven peritoneal penetration, if you explore the wound, ultrasound, hair in the X-ray, their positive or negative predictive values are not very high, about the same as would be to base the operation on whether the patient is a woman or a man, which is not very accurate. So far we established that the peritoneal violation involves about 60% risk of significant injury. If you don't know if the peritoneum is breached, it's about less than 10%. It will show that it's intact, of course, there is no injuries there. And one of the conclusions from this study was that the peritoneal penetration as such is not a very good indicator of a significant organ injury. And one of the conclusions from this study was that the peritoneal penetration as such is not a very good indicator of a significant organ injury. So what else do we need to know about this patient? What about CT scan or laparoscopy? CT scan was reviewed already before this morning, so I don't go through much, except it is unreliable in injuries of the bowel and diaphragm, although it's getting better. This study from Christine Graham is pretty old, and the CT scans got better. And I think this studies from Columbia showed that we can use serial ultrasound and CT guided management and have pretty good results, safe management. Nevertheless, in showing peritoneal violation, it's pretty accurate. This is from Baltimore. But again, as I said before, that as such is not a significant or good indication for presence of significant injury. Laparoscopy is very popular. You can do it either as a screening test, which means once you detect the first injury, which needs treatment, you do a laparotomy, or you try to find all the injuries and maybe also treat them laparoscopically, which sometimes you can do. This is just a chart from the United States by Dr. Simon showing that when the laparoscopy increases the negative laparotomy rate. I'm not sure what to make out of this study. There's this huge increase. And to me, this tells you that actually laparoscopy doesn't have a big difference, but it's open for discussion. In any way, the fourth study we did is a 5-year prospective randomized study which ended in 2002. We included not just the anterior abdomen, but flanks and lower chest as in previous studies. And then we actually did 2 studies in one. We stratified the patient according to high-risk patient with proven peritoneal penetration, and then the low-risk patient, which we didn't know whether the peritoneum was intact or not, where there's less than 10% chance of having an injury. And this was incorporated in the routine management, so everybody who did calls and was able to do a laparoscopic cholecystectomy was able to participate. So these were not highly skilled, super specialized laparoscopists. These were trauma and general surgeons taking call and having some experience in laparoscopy. And this is the way the study was done. Those with the bleeding, peritonitis, cardiac tamponade went immediately to operation. Those with high-risk group were randomized either laparotomy or laparoscopy. Those with low risk of significant injury had their wound explored. If it's intact, the patient was discharged. If not, they were randomized to laparoscopy or non-operative management. Looking first on the high-risk group, you can see that the non-therapeutic or unnecessary laparotomy rate dropped significantly within the group, which this is laparoscopy, this is laparotomy. So there's a significant decrease in unnecessary laparotomies. However, that didn't change or affect a lot the hospital length of stay and didn't have any effect on the cost issue. So even if the non or unnecessary laparotomy rate dropped a lot, it didn't translate to benefit in terms of length of stay or hospital cost. Looking at the other studies, which none of them are randomized except the one we did, shows a similar trend that you prevent a lot of unnecessary laparotomies in the order of about 50 to 80% while doing laparoscopy. So that's good news. The bad news is we think that although in the previous study you could show a decrease in morbidity, length of stay, or cost in most studies, the only randomized study showed that the difference wasn't that big as was thought it was before. The second group, the low-risk group, first of all, only a few of them had an operation, so it's a pretty good selection process. There was no difference in length, or there was a slight difference in length of stay in the benefit of non-operative management, but the big difference was in the cost. It was about 1/3 of the cost to treat the patients non-operatively, as safe as they would have with the laparoscopic procedure. Also, the sick leave requirement was much less in the non-operative group. So we thought that the moderate risk patient, the laparoscopy decreased unnecessary operations, but that didn't translate to much benefit. It did some, but not as much as we thought it would. In low-risk patient, it was safe to treat the patient non-operatively, and involving laparoscopy would have increased the cost by 3 times. So we don't recommend laparoscopy as a routine procedure for all patients, but there might be a subgroup of patients who might benefit from that. And that's a 5th study we did about diaphragmatic injuries. Just a few comments on that. First of all, that it's fairly high in thoracoabdominal trauma to have an injury, or high risk to have an injury in the diaphragm. On the other hand, most people who have the diaphragmatic injury also have an injury to other organs which requires operation. So you detect the diaphragmatic injury in most cases. Laparoscopy is pretty good in detecting diaphragmatic injuries. There's one missed diaphragmatic injury in this series of 8 patients published recently. This was a patient with splenic injury where you can see the posterior diaphragmatic injury. What happens naturally if you don't treat the diaphragmatic injury, we don't know. There are 3 animal studies showing that the spontaneous healing occurs, but we don't know how it happens in humans. So we did a study based on those 2 randomized studies, combined them to either those who had exploration or those who had observation, and just show that they are comparable. And the diaphragmatic injury, there were 4 patients in the explored groups. You can see there, 3 of them didn't have any other significant injuries. And there were 2 delayed presentations, one 2 months and one 2 years later with significant morbidity. They both survived, but this patient had a lot of reoperation, plastic surgical reconstruction, a lot of complications of that. So our result was that there's about 17% risk on the left-sided thoracoabdominal scapula to have that diaphragmatic injury. And it could be something where the laparoscopy could be useful. So concluding the laparoscopy part, excluding peritoneal penetration or detecting that, although that doesn't necessarily help us a lot, it decreases non-therapeutic laparotomy. The number needed to treat is about 4. And it has accuracy in diaphragmatic injury, some problems with others. We need really more research based on strategies, not just using laparoscopy, but laparoscopy-based strategies compared to others. So this again incorporated the information from the last study. And based on this, this is our current algorithm how to treat stab wounds, and this is my take-home message, if you like. So if there's a stab wound of the anterior or flank of the abdomen, the patient has a surgical abdomen, bleeding, peritonitis, cardiac tamponade, you operate them, no question of that. If not, then you explore the wound. The wound is superficial, you discharge the patient with the intact peritoneum. If confirmed that you do a laparotomy or laparoscopy, in some cases you can use, it is allowed. If you don't know if there is a peritoneal penetration, you observe the patient for 1 or 2 days. The exception is the left thoracoabdominal wound. Even if the patient doesn't have any symptoms, we do a diagnostic laparoscopy just to exclude the diaphragmatic injury. And just to remind you that stab wounds of the lower back we treat completely differently. They do a CT scan and then we, depends on the finding, have a different treatment algorithm. So I hope that summarizes the treatment we do with stab wounds in Finland. This is just to show you pictures of when you come to Finland that we can offer you a midnight sun and a drink and some nice fish. Thank you very much.